Hello everyone, myself Dr. Prateek Garg. So today's topic is pre-malignant lesions of oral cavity and oropharynx. Very important topic by means of examination point of view, and also in our OPD, that is outdoor setup, we see a lot of patient with a history of tobacco chewing, betel nut chewing, presenting with some sort of oral lesions, very common. So what are the pre-malignant lesions? Let's start with leukoplakia. You can see this curdy whitish glistening like plaques all over the tongue. This is a picture showing whitish these plaques over the tongue, and with the torchlight sometimes they will be the glistening, that means they will be reflecting the light. Okay, so what is leukoplakia? This is a typical picture of leukoplakia, the whitish glistening like appearance or the plaque over the tongue, over the buccal mucosa, over the palate, and some other sites, may happen over the lips also. So how you will differentiate leukoplakia from the other structure? Firstly, if we try to rub out this whitish plaque with the help of the platula or tongue depressor, it will not just rub off. You can't rub off this whitish plaque. So that is an indication of leukoplakia. If we rub out the candidiasis in the oral cavity, that is also, candidiasis also present like the whitish plaque. But if we rub out the candidiasis with the spatula, so it will bleed. What will do? The whitish tissue will just rub off and the bleeding surface will be present beneath the whitish tissue. So that is candidiasis. If we talk about leukoplakia, you can't rub off this. So this is whitish patch in the mucosa that cannot be rubbed off and that cannot be characterized clinically or histopathologically as any other disease. So if we took the biopsy, so we can't see any other disease histopathologically, and clinically we can't see the candidiasis or Vincent angina or the diphtheria, that is also consists with the grayish white membrane. Okay, so leukoplakia is a whitish plaque that cannot be rubbed off and cannot be diagnosed as other disease clinically or histopathologically. It is one of the most common pre-malignant condition. So what happens? This leukoplakia with time may convert into the erythroplakia and then may convert into the cancer of the oral cavity, most commonly squamous cell carcinoma of the oral cavity. You know what is the most common cancer in India in males? That is the cancer of oral cavity, and the most common site is gingivobuccal sulcus. Okay, and worldwide if we talk about, most common cancer is cancer of oral cavity, but the worldwide most common site is carcinoma of the tongue, whereas in India the most common site is the cancer of the gingivobuccal sulcus. Now if leukoplakia, this is associated with the tobacco chewing, that is the leukoplakia will be seen more in the persons who are chronic smokers. So how you have to treat? So we have to treat by, firstly we will ask the patient to stop the smoking, and we can do the close follow-up. We have to see whether there are some changes, it is enlarging or whatever it is. So we have to take a close follow-up, or we can do the excision of the leukoplakic patch. We can excise this complete whitish patch. Other reason is erythroplakia. Look at the diagram. This is a erythroplakia typical presentation. You can see the red ulcerative lesion in the palate. So there is red plaque on the mucosa. This erythroplakia, if you try to rub out, it will bleed. This has got a higher risk of cancer as compared with the leukoplakia. If you see the erythroplakic patch, then patient will be more prone to develop the cancer. Again, this is being managed by the excision, deeper excision, and then having a closed follow-up. That means they will ask the patient to routinely visit the OPDs in month gap, 2-3 months gap, or maybe in days gap. So I hope look out at the picture of erythroplakia. Now the third lesion, submucous fibrosis. We also say it OSMF, that is oral submucous fibrosis. Now look out at the photo again, the whitish mucosa appearance of the buccal mucosa. So complete whitish turnout of the buccal mucosa. Now what is the submucous fibrosis? By the name itself says there is the fibrosis of the submucosal layer. So what is it? It is characterized by the inflammation and progressive fibrosis of submucosal tissues like lamina propria or the deeper connective tissue. There will be excess and excess fibrosis. How this happens? There may be some irritating factor that will lead to excessive fibrosis. Maybe like the betel nut chewing, supari chewing, the patient or the persons with a history of betel nut chewing or the tobacco chewing, sometimes they just put the tobacco and they just keep it here, tobacco. So that will cause a constant irritation in the buccal mucosa, and there will be changes happening in the submucosal layer. And chewing betel nut, it consists of erythroplakia. This erythroplakia is majorly responsible for the submucous fibrosis. This OSMF, we have seen the patient OSMF increase incident the patient with a vitamin D deficiency. So now this has been seen that vitamin D deficiency will also lead to increased OSMF. Now it starts generally with the redness, then comes the blistering, and then occurs the local ulceration inside the mouth, which will further replaced by the stiff fibrous tissue leading to OSMF. So what will happen in advanced stage? The oral mucosa will loses its resiliency, that is the elasticity of the oral mucosa will get disappeared, and patient will present with a decreased mouth opening. You can't open the mouth completely. So there will be decreased mouth opening because this fibrosis will lead to stiffening of the buccal mucosa. How we can treat this? Submucosal intralesional injection of the steroid along with the hyaluronidase can prevent the further damage. So steroid will reduce the local inflammation, hyaluronidase which just lies the fibrous bend. So that's how we can treat. Then other option also like the laser excision of the OSMF followed by the grafting. So OSMF is again a pre-malignant condition. Now the fourth condition is lichen planus. See, we all know lichen planus, we remember the lichen planus by the 5P. So these 5P are for the skin lichen planus, not for the buccal mucosa, not typically for the oral cavity lesion. So if the lichen planus is present over the skin, so it will present with the 5P, that is planar, polygonal, pruritic, purple and papules. So 5P, what are the 5P of the lichen planus of the skin? Purple, pruritic, polygonal, planar and papules. So you can see the lichen planus will have some purple, like this purple polygonal like appearance, which is little bit of itching will be there, and there will be the papule like eruption. So this is a lichen planus in the picture of the tongue. You can see some polygonal patches with the whitish patches in between. You can see this zigzag irregular like appearance. You can see here. So this is not leukoplakia, this is not candidiasis, you can't rub it off. So there will be some hampered alternative or some sort of zigzag whitish fibrous or whitish bands along with some redness. So lichen planus of the oral cavity typically have the Wickham striae, that is a white lacy striae. So these are the white lacy striae will be there. I'll mark it with the light blue color. So these are the white lacy, some Wickham striae we say them. So white lacy striae will be there, interrupted pattern will be there, there will be the constant pattern. So irregular zigzag Wickham striae will be there, and there will be increased sensitivity of the oral mucosa to hot and spicy food. So patient will typically complain that he can't tolerate the spicy food, he can't tolerate the hot food, and there will be the roughness in the lining of the mouth. So there will be the irregular or roughness in the lining. How you will treat? So treatment is again the steroid. We will give the oral steroid along with the local application of the steroid, and for the longer term we can use the dapsone or methotrexate. These are the immunomodulator. So that's how we can treat the lichen planus, and again it's a pre-malignant lesion. That's all. So I hope you got a better idea. Thank you.